Hello, everybody. Want to welcome you to 2021 Digital Board Review. We actually used to do these a number of years ago called Dermpath Blitz. And now we have digital ability to do these sessions. We're going to do this digitally. We've kind of gotten used to this with the COVID era Zoom talk. So this is something you'll be able to look at, review on your own. Feel free to share it with your friends, colleagues. And I think if you can answer these questions, there's 60 questions we're going to go over today. If you can get all of these right, you're going to definitely pass the board. I think if you probably get 70 to 80% of them right, you're going to be in good shape. If you're down to 50 to 40%, I'd be a little concerned. But I think if you're in the 70 to 80% category, at least from the Dermpath perspective, you'll be in good shape. So the two sponsors of this session are me and my laboratory, Cockerell Dermatopathology Laboratory, and then Dermatology Authority. Kim Campbell, a good friend of ours, is got this program that helps to pair dermatology residents and others with job opportunities. So I want to thank her and her company for helping us with this as well. So would like to have you guys feel free to reach out to her if you're looking for a job or other opportunity down the road. So basically, this is the way that this schedule is set up. The e-slides and the exams are going live. They went live on the 19th. I'm recording this a couple of days later. On the 25th, which is coming up in 4 days, this case review will go live. So I'm recording this after the e-slides are live. And then on June 28th at 7 o'clock Central Standard Time, we're going to have a Q&A for an hour long by Zoom or longer than an hour if we want to go longer. This will be if you have any questions about this. Or questions about anything about dermatopathology or about the board examination, anything you think you would like to learn about or know. The Dermpath part is an important part of the exam. I mean, if you don't pass it, you can flunk the whole thing. So it's not like, like a bar exam where you can, do bad on the multiple choice, but do great on the essays and still win and pass. Here, you actually have to pass this or you're not going to get in. So you have to pass the board, the Dermpath part of the board. Now, there are 60 cases we're going to talk about today. And again, these are good sort of select cases that if you know these, we feel pretty confident you'll be able to pass the exam without any problem. These 60 may not actually be on the exam. Obviously, they're going to have probably some other things that are like that, but these will be sort of analogous to the questions that you'll be asked. And some of these for sure will be on the exam. So some of them are just so generic that they always end up on an examination. And some of them will be really easy to you. Some of them will be maybe a little more challenging. So if there's something pretty obvious, I may not spend very much time with it. If there's something that's a little bit more challenging and difficult, I will spend some more time with that. So let's get going. And the first one of these, and again, the way this is done is by Path Presenter, which we really appreciate Raj Singh and his colleagues for developing this software. The only bad side is if you sort of have a little bit of a slow hand, you can easily, it takes a while to get this thing oriented just right. So, but anyway, we're going to take a look at this. And again, you need to make sure that you have a good approach to diagnosis, how you're approaching a slide. So by this time, most of your third-year residents, you should have some kind of an approach that you use. I always like to start off at low power, ask if I did something that's inflammatory, neoplastic. If it's inflammatory, which of the 9 patterns of inflammatory skin disease is it exhibiting? And then if it's neoplastic, benign or malignant based on size, symmetry, circumscription, and then other ancillary features, what kind of differentiation is exhibiting. So again, I've given that type of presentation, other talks, make sure that you have some kind of an approach that you can use, because the last thing you want to do when you get an exam is just go in there and start, shooting from the hip. Because if there's something you don't know, you need to be able to, instead of panicking, you need to push the pause button, step back. And so I'm going to work through systematically the approach to the slide and using my approach so I can actually make a diagnosis. So we have a low power view. Doesn't look like there's much at low magnification. So it's certainly not going to be a neoplasm. It's going to be probably inflammatory process. See, there's a superficial perivascular infiltrative lymphocytes here, but it's not really lichenoid. It's not obscuring the dermatodermal junction. And you have 4 choices here. So there's a 55-year-old woman came in with multiple lesions on her lower extremities. Every word in these stems is important, by the way. So the board is putting every single word in here means something to you. So pay attention to everything. So woman, pretty common. Lower extremities, pretty common location for this. And then you're looking at 4 choices here, 5 choices rather. And hopefully you're able to see over here that there is a cornoid, C-O-R-N-O-I-D, cornoid lamella with these dyskeratotic keratinocytes and this column of parakeratosis right above that. That is a classic finding for porokeratosis. And usually the legs is one of the more common locations for this. They're very commonly seen in women also. You often get an inflammatory infiltrative lymphocytes. Notice that there is no interface dermatitis here. There's no true vacuolar alteration. This is not a true lichenoid infiltrate. It's just a superficial band-like infiltrative lymphocytes with this cornoid lamella. So this is porokeratosis. It very well could be DSAP. There's a little bit of solar elastosis. So it could just be the multiple porokeratosis that's not associated with sunlight. And here's another cornoid lamella over here. So notice it's a column of parakeratosis that usually sort of angles into the center of the area of the central annulus that you see clinically. And it's very common to get a little lymphocytic infiltrate. So this is not discoid lupus. It's not a benign lichenoid keratosis because it's got the cornoid lamella. If it didn't have the cornoid lamella, that might possibly be a little closer to the diagnosis. Obviously, it's not a viral exanthem, so it's not an actinic keratosis. So they're testing your ability to recognize the cornoid lamella here with the lymphocytic infiltrate. Not going to ask you the different types of poro. They just want you to recognize that it is poro. Okay. Number 2. We've got a gentleman. He's a 45-year-old man who has a history of HIV, comes in with multiple lesions on his lower extremities. And the best diagnosis here, notice it's got this irregular epidermal hyperplasia. It's got this area where there are lymphocytes at the base of these aggregates of this epithelium, a lot of pseudoepitheliomatous hyperplasia here. We have multiple sections to look at on the slide. Let's actually take a look at this one, which is probably even a better one to look at because it doesn't really have all the pseudoepitheliomatous hyperplasia. But notice that it's got, unfortunately, and just as an aside, this is a shave biopsy. And then on the board examination, if they're going to give you diagnoses of inflammatory skin disease, they're almost always going to give you a punch biopsy. So this is an inflammatory process this time. So this probably would not be the type of slide they would give you for this in this case. But here we've got this band-like infiltrate obscuring the dermatodermal junction, wedge-shaped hypergranulosis, hyperkeratosis overlying it with lymphocytes and irregular epidermal retinas. So if you just saw this, the classic pattern of this is lichen planus. It looks just like lichen planus. The other slide that I showed, the other section I showed you earlier, shows a little bit more pseudoepitheliomatous hyperplasia. And this one down here almost even looks like a keroacanthoma almost in some areas. This is actually an example of hypertrophic lichen planus with pseudoepitheliomatous hyperplasia simulating a carcinoma. So it's not a cancer. This is hypertrophic lichen planus. Now, HIV infection, that may be a little bit of a red flag here. This does not have to be seen in HIV infected patients. In fact, it's often seen in older individuals on the lower legs, most commonly. So the HIV is not that important. It has been associated with HIV infection, but that's not that important in this situation. But it is multiple lesions, not one lesion. So that would favor the diagnosis. So it's not a squamous cell carcinoma. It looks like a squamous cell carcinoma in that bottom section that I showed the first time. But if you have this area over here, it shows a classic lichen planus pattern. You have to realize that it's not squamous cell, that's pseudoepitheliomatous hyperplasia. And that's why the diagnosis is not squamous cell carcinoma in this case. So it's not secondary syphilis. Again, that doesn't usually, it will give you more plasma cells than we see here. It could give you, pseudoepitheliomatous hyperplasia, but it wouldn't give you, it would give you more plasma cells. We don't have any plasma cells here. This infiltrate is consisting almost wholly of lymphocytes. So this is hypertrophic lichen planus, obviously not chromoblastomycosis. It's not a lichenoid solar keratosis. There's no atypia at all the keratinocytes here. So this is a nice example of hypertrophic LP. Okay, let's go on to the next slide, number 3. Okay, and here your question was, go higher magnification, and you see a low power. It doesn't look like a neoplasm here. This is a 23-year-old young individual, comes in with crusted papules on the chest and back. So it's a truncal eruption. And you have a choice of 4 things here: erythema multiforme, pityriasis lichenoides, lymphomatoid papulosis, PR, and arthropod assault reaction. And so this is the 5 choices are inflammatory diseases. So normally we like to ask yourself, well, and I recommend looking at slides without any information first, but you look at this and say, okay, it's probably inflammatory. There doesn't look like there's any neoplastic cells in it at all. What's the pattern? Superficial and mid to deep perivascular infiltrate with interface dermatitis. There's an obscuration of the dermal junction here, so there's an interface dermatitis. It's got parakeratosis and crust. That's also important, and notice that it's kind of confluent over a broad front. So again, confluent parakeratosis. This one actually even has a little bit of the orthokeratosis overlying it. It often doesn't, but this is probably because it's a relatively early lesion. It's got a lot of extravasated erythrocytes. The infiltrate consists almost wholly of lymphocytes, and it's got diskeratotic keratinocytes, and it's got some epidermotropism. And if you look in the cornified layer, it actually can have some crust up here. It's not just parakeratosis. So there's abnormal cornified material plus serum and crust. This is a classic pattern for pityriasis lichenoides. Now, this would probably be maybe a subacute lesion of pityriasis lichenoides. Usually the classic Mucha-Habermann disease gives you a very dense, superficial, deep, wedge-shaped infiltrate. This doesn't have that. So this would probably be more like pityriasis lichenoides subacute or pityriasis lichenoides, maybe chronica. That's a relatively acute lesion of pityriasis lichenoides chronica. So people with pityriasis lichenoides can have it for years, but they can develop acute lesions in the setting of that. So anyway, this would be a nice example of pityriasis lichenoides. It's got all the pattern of that. So why is it not erythema multiforme? You never get this kind of crust with erythema multiforme. This is not seen in EM. That kind of parakeratosis with crust over a broad front. That's not what you see in erythema multiforme. That's usually, if there is any crusting or anything, that happens because the epidermis has been necrotic. And so you don't see that. You usually don't see the extravasated erythrocytes here. So that's not the best answer. It's obviously not lymphomatoid papulosis. That's usually a superficial and deep wedge-shaped infiltrate. Sometimes you can get different patterns that can be more band-like, but that would give you eosinophils often and atypical lymphoid cells, neither of which we see here. It's obviously not pityriasis rosea. That does not give you an interface dermatitis. It gives a slight spongiotic dermatitis. It does have extravasated erythrocytes, but it doesn't have the interface dermatitis with the diskeratotic keratinocytes, and it's obviously not a bug bite. Now, pityriasis lichenoides does not give eosinophils. So that's one of the few things in dermatology and dermatopathology we can usually say with certainty. If you see EOs, it's almost never pityriasis lichenoides. So if you see eosinophils, you can pretty much reject it. Okay, so that's a pretty good example of pityriasis lichenoides. Hopefully you all got that one right. Now let's take a look at this next one. Again, these are inflammatory skin diseases here. So we've got at low magnification, looks like a relatively sparse infiltrate. When you see dark cells at low power, that favors lymphocytes. So we're going to look at this, and you have the stem here is that of a 47-year-old man who comes in with a lesion on the back. And you have 5 choices again. Once again, they're inflammatory skin diseases. So they're not throwing in a neoplasm here. So you know, you're doing an inflammatory process. So you don't have to think about the neoplastic pathway. So let's look at it. Superficial perivascular dermatitis. Maybe it extends a little bit around that adnexal structure down here. Let's see what kind of cells we're looking at low power. We know there's a lot of lymphocytes. And then we start noticing that there are all of these dark cells, all these melanophages. Some of them are down in the mid-reticular dermis. They're pretty deep in the lower papillary dermis and even in the reticular dermis. When you see melanophages deep, when they get down into the reticular dermis, that's a clue to fixed drug eruption. Okay, it doesn't mean fixed drug eruption, but it means that the inflammatory infiltrates occur over and over at the same site, so that the melanophages aren't just located up here, like you see, let's say with maybe a morbilliform drug eruption that knocks off some keratinocytes, then gives a few melanophytes that go down into the papillary dermis. They get kind of in this area down in here, then you start thinking, could this be a fixed drug eruption? If you get an early fixed drug eruption, you usually see a superficial and deep infiltrate with lymphocytes and usually eosinophils plus some melanophages. If it's a little later on in the stage, you may not see so many eosinophils and the inflammatory infiltrate may not be as deep. So they'll probably show you more prototypical examples. So they might show one that does have some eosinophils on the examination. But here you can see it does have dyskeratotic keratinocytes, which is classic. It's still got some residual interface dermatitis here. Okay, so those are other features that you see with fixed drug eruption. So the classic criteria, superficial and deep infiltrate with lymphocytes, some eosinophils, with deep melanophages, with interface dermatitis, with dyskeratotic keratinocytes. As time goes on, the inflammatory infiltrate gets less intense, but because it occurs over and over again at the same site, you do have the residual melanophages that occur relatively deep. And this one, you still have the interface change with the dyskeratotic keratinocytes. Notice that it still has a basket weave cornified layer. Again, because this is occurring in the epidermis, it kills the epidermis. It doesn't have time to produce a parakeratotic cornified layer. So when you see all of these changes together, looking at the choices, by far, this is the best diagnosis. Now let's look at the other choices. Erythema multiforme, not as good of an answer because it's got the deeper melanophages. It's in the same family as erythema multiforme, but the clinical, one lesion, so that would throw it out because erythema multiforme is not going to give you one lesion. And also the deep melanophages, that tends to throw it out. What about erythema dyschromicum perstans? The deep melanophages and the dyskeratotic keratinocytes militate against that diagnosis. And also, that wouldn't be one lesion. That's a widespread process with reticulated epidermal hyperpigmentation. Post-inflammatory pigmentary alteration. This is a type of post-inflammatory pigmentary alteration, but it's got the dyskeratotic keratinocytes. So that makes it a better answer than that. And then finally, toxic epidermal necrolysis. Again, that's a diffuse confluent epidermal necrosis of the entire epidermis, not the inflammatory infiltrate area with the melanophages. So even though there's a little tougher question, some of the choices are tougher. You'd have to know this pretty well to get this answer correct, because if they're showing you a relatively late stage of fixed drug eruption, it is gettable, and you should be able to make the diagnosis when you use your process of elimination and knowing the criteria for the diagnosis. Okay, so this one's got two pieces on here. I'm going to flip it over here, and we're looking at a low power. We see, again, looks more like an inflammatory as opposed to a neoplastic process. Turn it over, and one also be don't afraid if there are more than one section on your slide to look at more than one section. You may look at one, like we did with the hypertrophic LP earlier, and say, oh my God, that looks like a squamous cell. But you got to look at the other piece and say, there's an obvious lichenoid infiltrate up there that looks pretty lichenoid. So I think it's probably a good idea to look at all the sections on your slide. If you think you can get it on one and you don't think you need the other one, that's okay. But I would strongly recommend looking at all the sections, and also start off at low power. See how many sections are on the slide to begin with. So here we got the question we're asked is a 35-year-old erythremic woman presents to the dermatology clinic for evaluation. So she's erythrodermic. Okay, right there from your residency training, you know that the number of lesions that cause an erythroderma are probably only about 8 to 9. That's always good news when you can limit something from 100 down to just a relatively few quickly. So you know some of the things that give erythroderma: atopic dermatitis, psoriasis, pityriasis pilaris, mycosis fungoides, erythrodermic drug eruption. Something, so there's a few others, but those are the major ones that you should think about. So you're dealing most likely with one of the psoriasiform dermatitis. People are papulosquamous. Well, I'm not a big papulosquamous guy. I like to think of things as more psoriasiform, looking like they look more like psoriasiform, like psoriasis. So I start thinking down that pathway. And what part of the body are we on here? We've got very deep, large follicles rooted in the subcutaneous fat, so we're probably on the scalp. That's also helpful because if those various diseases give you erythrodermas, there's some that like the scalp a lot. They start on the scalp. So we look at low magnification, we notice that there is a psoriasiform hyperplasia of the epidermis. The epidermis is thicker, there's more acanthosis, there's a long elongated epidermal rhesia. But when we look at them, are they really long and thin like we see with psoriasis, or are they more kind of bulbous and fat like we see with maybe some other conditions? Is there any spongiosis? Well, maybe there's a little bit, but there's not a whole lot. Is there anything else that we see? How about loss of the granular cell layer? Well, there's still granular cell layer up here. It's lost a little bit in some areas, but it's still present. Here's hypergranulotic here. And then let's look at the cornified layer, if there's anything unusual about that. And we notice that there's this infundibulum, this follicle that is filled, it's plugged with this cornified material that looks like it's plates of thick hyperkeratotic cornified material stacked one plate on another. And you can see there's some parakeratotic nuclei interspersed in some of these areas over here. You've got this alternating ortho and parakeratosis going both vertically and horizontally with these fat bulbous epidermal rhesia. Hopefully that instantly triggers in your mind with the follicular plugging, the diagnosis of pityriasis rubripilaris. So this is PRP. And you have a choice here of, this is a second order question. Okay, so you see this, you say, gosh, this looks like a psoriasiform dermatitis, but they're asking, what do you expect to see in the patient? Okay, so they expect you to be able to pick up the diagnosis of PRP here with the biopsy. And they're asking you irregular pitting of the nails, meaning that's what you would see in psoriasis, oil spots in the nails, like you would see in psoriasis, follicular keratotic papules on the dorsal fingers. Well, we've got follicular spines here, like we see in PRP. So yeah, that would be seen on the dorsal finger. So that would be your best answer in this case. Generalized lymphadenopathy, well, that would be perhaps if you had dermatopathic lymphadenopathy with widespread atopic dermatitis, or possibly with mycosis fungoides, you might have MF involving the lymph nodes. Well, this clearly is not mycosis fungoides. And then peripherally eosinophilia, which you might expect to see with atopic dermatitis. So this, hopefully, so this would be on a scale of 1 to 10, probably about a 7 or 8 with regard to difficulty here. They're expecting to look at this, make a diagnosis of pretty difficult psoriasiform dermatitis. So the differential diagnosis looking at this would be psoriasis or PRP. So you'd have to say, well, this looks like ortho and parakeratosis. It doesn't have mounds of parakeratosis with neutrophils. It's got follicular plugging. It doesn't have the elongated epidermal rhesia like we would see with psoriasis, that irregular epidermal rhesia with thin suprapapillary plates with parakeratosis that contain the neutrophils. So that would rule out psoriasis. It's not atopic dermatitis. It's got the follicular plugging. It's got the so-called checkerboard flag sign that we see with the alternating ortho and parakeratosis vertically and horizontally. So that's not going to go along with atopic dermatitis. It doesn't have very much spongiosis. It doesn't have eosinophils in the infiltrate, although you can rarely see some EOs with PRP. So this is a good example of PRP histologically, and then they're going to ask you some of these second order questions here. This would be pretty tough for a board exam question, by the way. So just so you'll know, I'd be kind of surprised if they got that. So if you got this right, you should pat yourself on the back and feel pretty good about it, because that means you're going to be able to get most of the second order type questions that they're going to ask you on the exam. Okay. One other clue that can help you in PRP sometimes is if you see acantholysis. Now, we don't really have that here, but sometimes you'll see little areas of acantholysis in PRP. Usually do not see that in psoriasis. Okay. So we're going to move on to number 6 here. Okay. And this is another good inflammatory skin disease here. And so I like inflammatory skin diseases better than neoplasms. I'm a dermatologist. A lot of the pathology trained dermatopathologists like the neoplastic things like lymphomas and stuff like that. I personally love inflammatory dermatopathology. To me, that's just more interesting, and I like it better. So you're going to get some of these on the exam. They'll give you some neoplasms too, but I'm going to say it's probably going to be 50-50, maybe 60-40 inflammatory neoplastic things. So you're going to get a combination of both on the exam. So we're hitting the inflammatory stuff pretty hard for you here. And if you can get these, I think you'll be able to get anything on the board examination. Okay, so we got a 63-year-old man comes in with diarrhea and dementia and develops a rash Okay, well, there's another thing. That's one of my pet peeves. And dermatologists should never say the word rash. They should say eruption. Let the internist and the family physicians say rash. Dermatologists should say eruptions, cutaneous eruption. It's inflammatory eruption. Something is erupting in the skin. It's causing a dermatitis. It's not just a quote rash, which can mean just about anything. That's layman's term. So anyway, this is located on the face, arms, legs, and gluteal area. Okay, well, let's just look at what they're talking about. Diarrhea, dementia, and dermatitis. Those are the 3 Ds of what disease that you think about. Okay, well, hopefully you all know that goes along with a nutritional deficiency. I think it actually goes along with beriberi. We don't have much beriberi in the United States, but it is a nutritional deficiency which goes along with some abnormality there's a circulating disorder. So just looking at that, you should probably, if you look at the 5 choices, you should probably say, maybe this guy's got some kind of nutritional deficiency. We're going to look at a high magnification so we can figure out what the pathologic process is. And generally what these show, all of these look the same. Pellagra, I think pellagra is actually the one that's the 3 Ds with the flaky paint dermatitis. I think that goes along with it maybe more than beriberi. Maybe I was maybe wrong on that, but pellagra is the classic one. And then acrodermatitis enteropathica, multiple carboxylase deficiency, all of these people that have essential amino acid deficiencies, they all look the same. Basically, your epidermis and your skin needs these nutritional things to form a normal epidermis. And when they don't, what happens is you get ballooning degeneration of the upper part of the epidermis, just like you see here. So if they're going to show you one of these on the exam, it's going to look just like this. You're going to see some psoriasiform dermatitis of the epidermis, and you're going to see this ballooning, this pallor of the epidermis, which is confined to the uppermost layer of the epidermis in most cases. So you need these nutrients to get in here and to make a normal basket weave cornified layer. Otherwise, your skin gets flaky and crusty, and it looks like flaky paint, like someone that has pellagra. And all of those dermatitides, they all give you that sort of crusting, flaky paint kind of an appearance because of the cornified layer that's comprised of this. It's not formed well, and it's got this crust associated with this ballooning degeneration, this oozing of this liquid that goes, the serum that goes through into the epidermis because it isn't making a normal cornified layer. And usually you get a slight inflammatory infiltrate. It's usually relatively minimal, usually a few lymphocytes. You can get a little bit of papillodermal edema. You don't get eosinophils, so you don't get any of those things. You see a slight psoriasiform dermatitis with this ballooning degeneration seen at the outermost layer of the epidermis, just like you see here. So this is what they're going to show you. All of them look the same. They're not going to put 2 of them down that are the same. So I'm not going to put pellagra and zinc deficiency together. They're going to put pellagra, and then they're going to have other things on it. So here we've got toxic epidermal necrolysis as the first choice. Definitely not that, because it's not killing the epidermis from, you don't get any interface changes. This is really not total death of the epidermis, just abnormally formed ballooning epidermal abnormality here. It's not erythema multiforme. We just talked about that a minute ago. It's obviously not psoriasis. Now, one caveat, late stage lesions of this disease can develop a more psoriasiform appearance, can look more like psoriasis, but they don't have the classic parakeratotic changes of psoriasis. They're not going to show you that. They're going to show you this, if you're going to see this on the exam. And then herpes virus infection. Well, no one would think of that. And they probably would not put on this Coxsackie virus, something that's also going to give you this type of ballooning degeneration. Now, herpes virus gives you ballooning with multinucleated cells, but it's not going to give you this pack. So this doesn't look anything at all like herpes. So of these 5 choices, and given that stem, even though it's a kind of a slightly difficult, histology, you should have gotten this just on the basis of the question without even really looking at the slide. But once you look at the slide, obviously, then it's diagnostic. Okay, so hopefully everybody got that right. Okay, moving on to the next one. All right, look at this one right here. In low magnification, we've got a superficial perivascular infiltrate of lymphocytes. I haven't even looked at the question yet, so I'm just looking at it without looking at anything. There's irregular psoriasis hyperplasia of the epidermis. There's some cornified layer abnormality here. There may be some neutrophils in the cornified layer and higher magnification. So this is kind of an irregular psoriasiform hyperplasia. It's got subcorneal collection of polys we see here. Okay, so what are some things that we think about when we see a psoriasiform hyperplasia of the epidermis with subcorneal collections of neutrophils and even a spongiform pustule in here? And well, there's a relatively limited differential diagnosis of that as well. We think of fungal infections, some bacterial infections like Bullous impetigo sometimes, but usually not the spongiform pustule. We think of psoriasis. Okay, so those are the three main things we think about right away. You're gonna have to prove otherwise to me that it's not one of those various things in this situation. Now, if it's psoriasis, it's going to be kind of an eruptive pustular psoriasis, because this isn't the classic form of psoriasis vulgaris, where we've got like nice elongated epidermal rhesia that are nice and long and thin and loss of the granular cell layer and thin superpapillary plates. We don't have that here. So this is probably going to be somebody that maybe they had a staph infection or strep and they developed kind of an eruptive lesions of psoriasis with pustular psoriasis. So this is a rapidly developing lesion of psoriasis in this case. This isn't going to be something that's more like a long-standing psoriasis vulgaris that you biopsy, say, on somebody's elbows or knees or something like that. So let's look at the choices here. 35-year-old woman, could be a man or woman here. Scaly lesions on her trunk. The best diagnosis here is candidiasis, nutritional deficiency. We just saw one of those. It didn't look anything like that. Tinea corpus, it definitely could be that. Seborrheic dermatitis, usually you don't get spongiform pustules in seborrheic dermatitis. And then last of all, psoriasis. Okay, so the differential diagnosis is fungus versus psoriasis, just like we said without even looking at the slide, which I would want you to do too. I want you to look at everything, say, I think it's probably going to be this. Then you look at your choices, and they say, well, let's go see if we can see any fungal infection in here. So if they're going to show you something like this with a candida down on the as a choice, you're going to be able to see it. Okay, you're going to see hyphal elements just entering the epidermis. So candida likes to go north and south. It's like drilling for oil. The pseudohyphae goes straight into the epithelium, as you see here. If you see dermatophyte infections, they like to live in the interface between the parakeratotic and the crust and the neutrophils and basically cornified layer. We don't have any basically cornified layer much at all. We just have this parakeratosis with the neutrophils. Here you have a mound of parakeratosis with neutrophils. So again, this is less likely to be a fungal infection, but they're not going to show you tinea that you couldn't see very, very easily with tons of organisms without showing you a special stain, just so you'll know. So probably in this question, they probably really wouldn't even put fungal and psoriasis down in the same question unless they showed you a PAS stain. So I don't think you're going to get that. So they might put something like psoriasis and some of these other things down here that we mentioned. They probably wouldn't put seborrheic dermatitis, but this is less likely to be seborrheic dermatitis given that it's got a small spongiform pustule up here. So this is pustular psoriasis in evolution. And the lesions might be scaly, they might be kind of crusted and scaly, but here under the microscope at least, we see evidence of an intraepidermal pustule that's formed. So this is an example of psoriasis here. Now, seborrheic dermatitis is going to give you the mounds of parakeratosis with some neutrophils at the edges of the follicular ostia. That's the classic location there on the scalp, the face. So this is on the trunk, which would not be a good location for seborrheic dermatitis anyway. And again, if they showed you one of the fungal infections, I think they're going to show you a PAS stain. Okay. All right, let's take a look at this one. Okay. One thing we like to do too is we ask ourselves, what part of the body are we on? Okay, what part of the body are we dealing with? Okay, so can you tell here? Well, there's a couple of follicles here that are rooted in the subcutaneous fat. Whenever you see sort of thin looking hair follicles like this that go all the way down to the subcutaneous fat, your first reflex should be scalp. So this is on the scalp. It's obviously not volar skin. We've got follicles. Notice that so we also ask ourselves, is this normal scalp or not? Well, the answer is obviously no. Whenever you see a biopsy from the scalp, there should be 8 to 10 follicles in antigens sitting down here in the fat, or the person's got an alopecia. So here we just see 2 follicles in the subcutaneous fat. Okay. And so this person's got a lot of hair loss here. And then we ask ourselves, is it an inflammatory alopecia or is it a non-inflammatory alopecia? If there's inflammation, where's the inflammation localized to? Is it a permanent or non-permanent alopecia? Is it permanent because there's scar and inflammation, or is it permanent because there's scar with no inflammation? Okay. If there is scar, what's the pattern of the scar? Does it hit only the individual follicles, like a rifle shot zooming into those hair follicles? Or is it diffuse, involving the whole thing, and the follicles just happen to get in the way, like you see with things like morphea, scleroderma, things like that, as well as folliculitis capitis or dissecting cellulitis? It just kind of gets separative folliculitis, starts wiping out everything. So those are the ways we approach alopecias. And here we've got 2 follicles. They're in this. And then another thing you can ask yourself is, are the follicles in the same stage of evolution or in the different stages of evolution/involution? Here we've got follicles, 2 of them look like they're kind of both shifting from telogen into catagen, from anagen into catagen and early telogen, both at the same time. And we've got a peribulbar infiltrative lymphocytes here. Hopefully this is the most, you're definitely going to see this on the examination somewhere. Okay, you're going to get this answer somewhere. You're going to be tested on this somewhere. So go ahead and be prepared for that. This is alopecia areata. 20-year-old man comes with evaluation of hair loss. And your choice here, telogen effluvium. We can rule that out right away because there's inflammation. Telogen effluvium is a non-inflammatory alopecia. So you get these bulbs, peribulbar infiltrates of lymphocytes with occasionally eosinophils. That's not going to be telogen effluvium, period. It's not going to be lichen planopilaris. Lichen planopilaris targets this area of the follicle. It targets the infundibulum and the isthmus. So there's inflammation. AA likes the bottom. Lichen planopilaris likes the top, likes in that area. Okay, and discoid lupus usually likes the DE junction between the follicles. So if you get like a diffuse lichen infiltrate, paradoxically, that's actually more likely to be lupus than it is LPP, which for some reason just likes to target those infundibular follicles more than it does the interfollicular epidermis. You would think the other way would be true, but actually it's not true most of the time. It's not trichotillomania. These follicles are both in the same stages of involution. Now, one thing, one caution, a caveat about people that have alopecia areata is they sometimes will get a secondary trichotillomania because their hair starts coming out and they say, oh my God, my hair's coming out, and they start reaching up and helping along. And they get a secondary trichomalacia, which is degeneration of the hair shafts within the follicular ostia. That's a sign of traumatic change to the hair shafts. And you can see that superimposed on AA. That's a little tricky. I don't think they're going to give you that on AA. I think they're going to give you something like this. It's pretty classic. And this is not androgenetic alopecia. And this patient may actually have a little bit of background androgenetic alopecia because these hair follicles are surrounded by these relatively large sebaceous lobules, which if you see what looks like the scalp on the, if it looks like the face, but it's on the scalp, and usually you'll get like about 5 or 6 follicles or more with these large sebaceous lobules around them. That's classic for androgenetic alopecia. So if it looks like it's on the face, but it's really on the scalp because the sebaceous lobules are large because they're being stimulated by androgens, that's going to be androgenetic alopecia. But here we've got peribulbar inflammation. That's classic for alopecia areata. Now, there's a couple other things we can talk about it with AA. Maybe we'll get into that later on. But if you see this pattern, and this is almost certainly what they're going to show you on the board examination, you should get this answer correct. Okay, so that is alopecia areata. Hopefully you all got that. Okay. All right, we've got another pattern here that's different. Okay, so here we go. We've got 2 together. And notice the pattern here. We've got a relatively dense and pretty diffuse infiltrate here. And we've got marked papillary dermal edema in this case. Okay, so what do you know? And in low magnification, these cells are not as dark and as jet black as we see with lymphocytes. Now, I'm not going to get into teaching those of you who haven't had conferences with me before about how to diagnose neutrophils at low magnification versus lymphocytes, but I can tell you that these are not lymphocytes. They're not dark enough. Those are jet black. They look black at low power. Well, here we don't have black. You can tell there's a little bit of pallor to them. That's what you see when you see neutrophils. And then you get papillary dermal edema. So low magnification, you might say, hey, lots of polys, papillary dermal edema. What's the most common diagnosis to give you that? And as we go to further magnification, now you believe me that yes, these are neutrophils. Almost everything's a neutrophil. There are no eosinophils here. Maybe there's one or two, but there's not very many. And then you get all this papillary dermal edema. So what gives dense infiltrates of neutrophils with papillary dermal edema with relatively minimal involvement in the epidermis? A little bit of parakeratosis here, but not a lot. Well, hopefully you all instantly would think of Sweet's disease here, Sweet syndrome. This is pretty basic Dermpath 101 for third-year residents. You guys should know this. So if I were to call you up at 3 o'clock in the morning and say, hey, I've got a biopsy here that shows a dense infiltrated neutrophils with papillary dermal edema, not much epidermal involvement, it really looks edematous, you should say that's Sweet's until proven otherwise. And indeed, in this case, that's what the board wants you to know. Okay, so they ask you, a 37-year-old woman evaluates for tender erythematous plaques on her face. It's okay. Sweets can involve the face and upper extremities. Which of the disease is associated with this? So they expect you to know this. So if you don't know this, you need to know it, because they say, okay, we're going to assume they're going to get this right pretty quickly, and then we're going to ask them a second order question. So which of the diseases are associated with this? Hematologic malignancy, kidney failure, GI bleeding, sepsis, or blindness? Well, in this case, you should know acute febrile neutrophilic dermatosis is commonly associated with underlying leukemias, usually leukemia, AML, those kind of things. Less likely lymphomas, but very commonly with leukemias. And that's not all of the things that are associated with that. But kidney failure, no, it's not associated with it. GI bleeding, no. Sepsis, no. Blindness, no. So that's pretty straightforward. None of the others are at all associated with Sweets. So if you could figure this out, then we can go pretty fast to pick up that it's hematologic malignancy that's associated with it. So pretty straightforward. They're not asking you here the differential diagnosis of other neutrophilic dermatoses, which can be more challenging sometimes. They're asking you here to pick up the diagnosis of Sweets and then to tell what diseases are associated with it. Fair game, totally fair game. And be prepared, because you're probably going to get a question about Sweets. Now, you're also going to get a question about this diagnosis. See if I can do it right here. Okay, yeah. This is on the exam for sure. So you're on there. So you may as well go ahead and be prepared. So don't even, this is not a matter of, are they going to ask me about this? Or, they're going to ask you about it. So just go ahead and say, good, I'm waiting for it. If they don't ask, you'll be disappointed. But you will be asked something about this disease somewhere on the exam. Okay, so what are we looking at? Once again, we're getting inflammatory disorder and low magnification. You can see that there's inflammation near these blood vessels here, and there are all these extravasated erythrocytes. So I know what this is looking at it at low power. I would certainly have a differential diagnosis that I would come up with, but I've been doing this for 30 some odd years, and I've looked at a couple of million slides and probably working on my 3rd million slide. So anyway, I could do this at low power and get the diagnosis. You need to have a systematic approach. So, okay, well, there's a superficial perivascular infiltrate. I can't really tell what these cells are, but they don't look like they're all lymphocytes again. Dr. Cockerell said they don't look black, so they're probably not lymphocytes. There may be some other kind of cells. There's a lot of extravasated erythrocytes here. I'm going to be worried about things that cause blood cells to leak out of blood vessels here. Maybe vasculitis, maybe PPPD, maybe scurvy, I don't know, but I'm going to at least be thinking about that. And then we're going to go to higher magnification. And sure enough, fortunately, this didn't scan super well. It's a little fuzzy, but over here, there are neutrophils and there is nuclear dust here. Okay. And there also are, look at all these nuclear dust particles here. Can you see that? Hopefully it's a little fuzzy. Sometimes when we scan slides, the scanner focuses on the glass instead of the actual tissue a little bit. So that's why it comes out a little bit fuzzy, but you can make it out here. There's obviously leukocytoclasia. And when you see this much leukocytoclasia, even if you don't see fibrin in the walls of the blood vessels, now the board's going to give you one that's got fibrin, pink hyaline material sitting in the blood vessel with leukocytoclasia, with neutrophils, with eosinophils, with extravasated erythrocytes. That's what you're going to see. This is an earlier stage lesion of the same process where we don't see a lot of fibrin in the blood vessels yet. But nevertheless, you can, and here's one that does have some fibrin in it. That's a capillary. It's got some pink around it. So that is actually a vasculitic blood vessel right there. But this is what you see when you get early leukocytoclastic vasculitis here. So the diagnosis here is leukocytoclastic vasculitis. Your stem, 55-year-old woman, concerning lesions. They didn't say palpable purpura, it'd be too easy, but they said concerning lesions on the lower extremities. That's the most common location. So that helps. The best diagnosis here, okay, and they're giving you some pretty challenging choices here. PPPD. Well, you can get a superficial perivascular dermatitis of lymphocytes with PPPD and extravasated erythrocytes, but not nuclear dust, not neutrophils, not eosinophils. So you can throw that out if you recognize that this is leukocytoclasia. Sweets, we just saw that, not near dense enough for sweets. Livedoid vasculopathy or atrophy blanche or lividovasculitis, another name for that. Basically, that gives you tons of fibrin in the walls of the blood vessels, usually with minimal inflammation. Sometimes you can get a little bit of neutrophilic infiltrate and a little bit of leukocytoclasia, but minimal, but lots of fibrin thrombi in lots of blood vessels, clotting the blood vessels with stasis alteration usually. That's due to your body doesn't have enough fibrinolytic activity anymore because of the ischemia, that you don't have any fibrinolytic activity left. It wipes it out because of the ischemia. So you get lots of fibrin. So that's out. And then septic vasculitis. Well, there you don't see leukocytoclasia in septic vasculitis. Leukocytoclastic vasculitis is an immune complex mediated process, and the breakdown products of the neutrophils come from the immune complex mediated complement pathway, et cetera. That's how the leukocytoclasia develops. In septic vasculitis, you get thrombosis of blood vessels with intact neutrophils. No leukocytoclasia. Lots of thrombus, no leukocytoclasia, but inflammation. And then in something like thrombotic vasculopathy, no inflammation, no leukocytoclasia, just lots of thrombosed blood vessels. So you can tell these things apart. They're criteria that help you to distinguish all of these from one another. So hopefully you all got this right as well. Okay, so this is leukocytoclastic vasculitis here. Okay. Let's move on to this one. Okay, we've got a challenging diagnosis here. And we've got, okay, so we're moving away from inflammatory disorders here. A shave biopsy taken from sun-damaged skin. Okay, so, and this is second order question. Let's read it. Let's go to read it. So look at it. We'll go back to slide in a minute, but we can say, okay, well, we're not inflammatory. Now we're in the neoplastic process. We'll go through how to do that, but let's look at the question. 67-year-old man, older man, and you can see he's old anyway because there's a lot of sun damage here, comes in for an evaluation of lesion on his chest. The lesion was biopsied. And which of the following immunohistochemical stains will highlight the neoplastic cells? And this is a little esoteric. I don't know that they're going to really ask this of you on this exam, but nevertheless, you're going to learn something just in case they might ask this, because this is a stain that a lot of dermatopathologists do use to kind of help distinguish this entity. But let's go ahead and take a look at it here and see. So the stains are S100 protein. What does that stain? It stains melanocytes. It also will stain Langerhans cells. LCA, leukocyte common antigen. Sometimes they'll just put the abbreviation on there, expecting you to know what that is. So LCA is leukocyte common antigen, also known as CD45. Well, obviously that stains leukocytes, lymphocytes, mostly. CK7, cytokeratin 7, what does that stain? that stains the cells in extramammary Paget's disease, and in Paget's disease, the breast. So that stains that entity. P63. Okay, well, that is a stain that actually stains squamous cell carcinoma in situ. That actually highlights the neoplastic cells of Bowen's disease, of Bowenoid lesions in the vulvar area and the penile area. So it's actually a stain that is used more by gynecologic pathologists than it is by most dermatopathologists. Usually we can recognize these things pretty readily without doing a lot of stains on these. And then G6DFP-15, that's gross cystic disease fluid protein 15, which is also used to stain extramammary Paget's disease. So what they're trying to do here is have you look at the slide and say, what's the diagnosis here? Well, there's this intraepidermal atypical proliferation of these cells here that are arranged in nests, and it's got a pagetoid morphology. So this is an example of squamous cell carcinoma in situ, pagetoid Bowen's disease, which is pretty sophisticated. I don't know that they're going to get into ask you this in the board examination, but at least you're learning about it right now. But this is an intraepidermal carcinoma. Okay, so that's the question. This is they're asking you the differential diagnosis of intraepidermal neoplasia. And so what are some of the things that give you a pagetoid intraepidermal neoplasia? Melanoma, Langerhans cell histiocytosis can do it. Merkel cell can do it. Sebaceous carcinoma can do it. Bowen's disease can do it. Pagetoid conditions such as Paget's disease itself, or both extramammary and mammary Paget's disease. Then there's also a few other very rare entities that can do it. I think I mentioned, Merkel cell rarely can do it, mycosis fungoides, pagetoid reticulosis. So there's probably about 6 or 7 things. So you need to know what those are and the stains that help you to distinguish those. So in this case, this doesn't look like Paget's disease itself. Those cells usually have a bunch more mucin in them. This has areas where there's full thickness involvement of the epidermis. It does have this so-called eyeliner sign, but that's seen a little bit more commonly in extramammary Paget's disease. But these cells really look more like the cells of squamous cell carcinoma in situ, and it's also noticed it's located on sun-damaged skin. And it's also on the chest, of a man. It's not near the breast area. So again, use everything to help you make the diagnosis. And this would actually stain positively for P63 in this case. So this is staining the cells of squamous cell carcinoma in situ, not the cells of Paget's disease, not the cells of Langerhans cell histiocytosis or melanoma, not the cells of mycosis fungoides that would stain positively with leukocyte common antigen, and CK7, which would highlight Paget's disease, breast or extramammary. So again, this is a sun-damaged skin intraepidermal neoplastic process here. So we just happen to be an example of pagetoid Bowen's disease. A little bit more esoteric. I doubt that you'll see this on the examination. If you can get that, okay, so that's a harder question than you're going to get. So if you got that right, then good for you. Okay. So if you look over in this area right here, this is probably the most diagnostic area of the whole slide. You've got full thickness keratinocytic atypia here. It's not just involving the basal cell area. And usually another thing that can help you is if you get so-called neoplastic parakeratosis, you get like atypical keratinocytic proliferation throughout the entire epithelium. That's more commonly seen with Bowen's than it is with some of those other conditions that we talked about. Okay, let's move on to the next slide. This is one you will get on the exam. Because the last one, yeah, probably not. This one, probably so. This reaction pattern, you most certainly will get on the exam. Okay, now when we talk about epidermal reaction patterns, for those of you that have ever heard me talk, I hammer on this pretty hard because basically what the concept here is that the epidermis can react in a certain number of ways in different diseases. Okay, there's about 10 or 15 different epidermal reaction patterns. There's epidermolytic hyperkeratosis, there's spongiosis, there's focal acantholytic dyskeratosis. There's all sorts of intraepidermal conditions that can give you reaction patterns here. We won't go through all of them today, but we're going to talk about this one, which is important. Okay, so this is a punch biopsy, and it's taken from the cheek. Well, you ought to be able to tell that it's probably taken from the head and neck area. It's got these large sebaceous lobules. This biopsy may have actually come from the scalp, but the stem says it came from the cheek, which is a common location. This lesion actually also can occur in the scalp. Is it inflammatory or is it neoplastic? Well, it's got something going on here that's not purely inflammatory cells. So it's a neoplasm. Is it benign or malignant? Well, let's see if we can look at it. It's relatively small. This whole thing's probably about, this may be a 4 millimeter punch. This whole thing's probably about 2 or 3 millimeters. That's very small. They punch the whole thing out. Is it symmetrical? Very much so. You draw a line right down the middle of it. You can fold this side right on the other side. It looks pretty much the same. Is it well circumscribed? Absolutely. You can draw a line right around the thing. So it's got all the 3 architectural hallmarks of benign. Is it epithelial or non-epithelial? Well, it looks like it's got some kind of an epithelium here. It's got these little small cysts involved with it. So it's benign and it's epithelial. Now let's ask ourselves what type of epithelium. We're going to higher magnification, and you see that it's got this lining here that's got these cells that are falling apart from one another. It's got these chorones and grains here. So it's probably squamous epithelium like that of the epidermis, but it's got this epidermal reaction pattern we talked about. Of acantholytic, cells are falling apart, dyskeratosis, cells are dying, they're becoming hyperchromatic nuclei, there's pycnotic nuclei, there's pink cytoplasm. So there's focal acantholytic dyskeratosis going on here, which is an epidermal reaction pattern that's seen in about 5 or 6 or 7 diseases. That's also good. You can narrow it down. So what conditions give you focal acantholytic dyskeratosis as a solitary lesion on the head and neck area most commonly, and it looks like a cyst clinically, or a little wart? Well, let's look at our choices. Well, these guys are being kind of tricky here in this case. Why? Because they're using more than one condition that can give you this epidermal reaction pattern. So they're expecting you to look at this, recognize it, recognize that it's solitary, put the information together, and then differentiate it from some of these other choices. So Derriér's disease, can you see focal acantholytic dyskeratosis in Derriér's disease? Absolutely. Is Derriér's a solitary lesion on the cheek? Never, never. So even though you get the same epidermal reaction pattern, it can't be Derriér's. So throw that out. Is it a keratoacanthoma? Well, it's exoendophytic like a keratoacanthoma. It's got that architectural pattern of a keratoacanthoma. But do you get focal acantholytic dyskeratosis in a keratoacanthoma? No, you don't. So throw that out. Can it be acantholytic squamous cell carcinoma? Maybe, but usually you don't get acantholytic dyskeratosis there. And you'd want to look carefully and say, well, maybe it is a squamous cell. I need to see then atypical keratinocytes with mitotic figures, things of that nature. Do we see any of those? No, we don't see that. So we throw that out also. And is this an actinic keratosis? Well, no, it's definitely not that. It's not an acantholytic actinic keratosis. You can see acantholysis in AKs. You can sometimes see a little bit of dyskeratosis in actinic keratosis, but this obviously isn't an actinic keratosis, an exoendophytic cystic type lesion. So the correct diagnosis here is warty dyskeratoma. So on a scale of 1 to 10, I'm going to throw this in the above 5. It's going to be harder than some of the other kind of questions because you're going to be thrown off. You're going to say, well, could this be Derriér's? It shows FAD. Hopefully you would say it can't be Derriér's because it's a solitary lesion. It's got the same reaction pattern. If they just showed you a high magnification view of this and said, what do we see here? You'd say, well, that's focal acantholytic dyskeratosis. That could be seen with Derriér's, just this high power view, but not everything else. So you have to use all of this information to get the right answer here. And, when we're doing unknown slide sessions, we say, well, hey, our goal is to learn, not to get the right answer. Well, now your goal is to get the right answer. You're on an exam. So you must get the right answers on these if you're going to pass. So we're no longer in a setting of learning. We're sort of in a setting of now we got to get the right answers here. Okay. Some of these on this practice exam, I think some of these questions may be beyond the scope of what you're going to get but we're going to give you challenging things that are, if you can get some of these that are beyond the scope, well, then you'll be able to do great on the exam as well, hopefully. Okay, let's move on to the next one. 47-year-old woman, a peritic persistent plaque on the posterior neck. Okay, let's take a look at this. Once again, they're probably going to give you a better biopsy on the board examination than this. Okay, but I want you to look again. We're talking about the concept of epidermal reaction patterns here. So what do we see? Is it inflammatory or neoplastic? Well, at this point, we're not 100% sure. They took a shave, and we really wish they would have taken a punch, but they didn't do that. They took a shave biopsy. So let's take a look at it. We've got some acanthosis of the epidermis. We've got some holes in the epidermis. So when you get something that looks like the epidermis is falling apart and there's holes in there, you should think of a couple of things. Number one, is it real or not? Is it fake? Is it an artifact or not? You know, is it like something that happened in the laboratory? Sometimes we see biopsy specimens that aren't processed properly, or maybe the specimen gets frozen and you get these little spaces in there. So you want to look at that and you want to make 100% sure that you're not, you're not just looking at an artifact. So the way to tell that is to see if there's actually something in those spaces. If there's serum, if there's cells, if there's inflammatory infiltrate, it's real. So this is real spaces in here in the epidermis. What's causing that? So what are some of where is it located? It's within the epidermis. It's not beneath the epidermis. It's actually in the epidermis. And as these intraepidermal blister. Intraepidermal blister. What are the three main ways of getting intraepidermal vesiculation? There's spongiosis, where there's fluid that accumulates between the cells in the epidermis, making it look like a sponge. There's ballooning, like we saw with the nutritional deficiency before, where the liquid gets inside the cells and they swell. And then there's acantholysis, where the cells fall apart, where the desmosomes are no longer there anymore. They're not hugging each other anymore. They're lost. And the cells are floating freely in the space like you see here. So this is acantholysis. There's no spongiosis here. There's no ballooning. This is acantholysis. And if you see acantholysis, we'll say, well, we just saw acantholysis before with the warty disc keratoma. Is there any disc keratosis? Well, there's a little bit here, but there's not the same that we saw with the warty disc keratoma. We saw the acantholytic disc keratotic parakeratotic nuclei and the chorones and grains, which, by the way, that's not specific for Derriers or Grover's disease or any of those things. It's seen in any condition where you see acantholytic disc keratosis. Coron just is the French phrase for round body. Grain means acantholytic disc keratotic parakeratotic nuclei. That's all it means. These are all chorones. Every one of these is a choron here. Okay, this does not mean it's Derriers disease. Does not mean it's Grover's disease. So here we've got this relatively diffuse acantholysis with all this purulent scale crust on the surface. It's progressing from the bottom of the epidermis all the way to the top. It's not only suprabasilar acantholysis. We have some disc keratosis as well. This kind of looks like the so-called dilapidated brick wall. And here's some disc keratosis up here at the cornified layer. Dilapidated brick wall. You know, unfortunately, the board isn't going to come to you with a parenthesis that says dilapidated brick wall. They're going to expect you to recognize this and say it looks like a dilapidated brick wall. It's got this diffuse acantholysis throughout the epithelium with some overlying parakeratosis, with some crust. What's the most likely diagnosis when you see that pattern? Well, obviously, it's Haley-Haley disease. Now, let's take a look at our choices here. One plaque, posterior neck. That's not a bad location. It's not the best location. The best location probably the axilla or the groin, but you can get on the back of the neck if patient gets the area that gets macerated, gets hot and sweaty. So it can occur in that location. So that doesn't mean that it can't be that. But they're asking you once again the differential diagnosis of acantholytic processes. Harder question, harder, because it's saying, okay, you recognize there's acantholysis here, but you could get pemphigus on the back of the neck. So that doesn't help you distinguish that from this. What about acantholytic solar keratosis? No atypicality in the keratinocytes. Okay, you don't usually get this diffuse so-called dilapidated brick wall pattern with an acantholytic actinic keratosis. That's usually just local acantholysis just above the basal cell layer. So that's out. No atypical cells here. What about Grover's disease? Well, there is a Haley type of Grover's, but what about that persistent plaque on the back of the neck? That's out. It's also a younger woman. You can get Grover's in women of that age group, but it's less commonly, and that wouldn't be a plaque. So that's out. So that's using the clinical to help you there. And usually the Haley form of Grover's is very focal. It's not diffuse like this. This goes over a broad front. It's a plaque. So that's out. What about Derriades? Well, once again, theoretically possible from the histology, but usually that doesn't give you the diffuse acantholysis throughout the epithelium, as you can see here, and also not a solitary plaque. So Derriades is out. And then Pemphigus vulgaris. Again, that's present just above the basal cell layer, no acantholysis throughout the epidermis. So this is gettable. You should get this diagnosis correct. Is it harder than the average question that they're going to have? Yes, probably looking at about 7 or 8 here. So if you can distinguish among these acantholytic processes like this, using this clinical information, you're in good shape. So hopefully you're able to do that here. And this is a good example of a Haley disease, and it's fair game. They theoretically could ask you something like this on the exam. Okay, let's look at this one. This is another one that you're going to be pretty much expected to recognize this pattern. Okay, so, and sure enough, the question they're asking you is a second order question. They're asking you, they're going to expect to get the pathology, and then they expect you to be able to answer a question about the pathology, about the clinical. So let's just look at it first, since that's what they're expecting us to do. What do we see? We see a punch biopsy, probably taken from the trunk. It doesn't have anything that looks really very diagnostic. It's certainly not the face, it's not volar skin. We've got a superficial perivascular trait of something going on. Once again, they're not all lymphocytes. Then we've got another, what looks like a cleft at low magnification. It looks like it's beneath the epidermis. Let's go to higher magnification and guess what these cells are once again. They're neutrophils. And what is the pattern of the neutrophils here? Now this, if the board is going to show you something that's prototypical, that's almost always uses immunofluorescence to make the diagnosis like this, it's going to look like it walked out of a textbook like this. So what disease gives you collections of neutrophils, and hopefully you recognize these are neutrophils mostly. You can sometimes get some eosinophils admixed in here. This is almost all neutrophils here at the tips of the dermal papillae. Okay, well, we know that there's several different subepidermal vesicular diseases that can give you neutrophils in the infiltrate. So you can get this disease, linear IgA bullous dermatosis, some forms of pemphigoid with neutrophils, EBA with neutrophils. When we see these clusters of neutrophils at the tips of dermal papillae like this, the best diagnosis, and I don't have to tell you what that is, you know it's dermatitis herpetiformis. You better know it. If you don't know it, you're in trouble. Okay, so at this point of your training, the board expects you to know this is DH. So they're going to say, okay, we know they're going to get DH here. If they don't get it, well, then they're really getting in trouble on the second question. But if they know there's DH, then then we're going to ask them a tougher question about things that can make it worse. There's one other thing that can sometimes help you with DH is if you see basophilia of the collagen, that's just an ancillary clue. Anytime you get abundant neutrophils and they kind of interact with the papillary dermal collagen, it sort of turns basophilic like you see here. And that's just a clue, but you don't need that here. Here you've got the obvious classic features of DH. So what kind of second order question might they ask you? They might ask you what kind of immunofluorescence pattern you're going to see. They might ask you some HLA haplotypes that may be associated with this condition. Well, here they're asking you which medications can flare the disease. Which meds flare dermatitis herpetiformis? Well, they've got SSKI, potassium iodide. Well, can that flare DH? Sure. Iodides cause neutrophil influx, so they can make it worse. So you don't want to give somebody iodides when they've got a lot of neutrophils in their skin. So yeah, that's the answer. What about captopril? No, not usually. Penicillamine? No. Gold? No. Lasix furosemide? No. So here you kind of have to know that iodide can do it. If you didn't know that, then you might be scratching your head. Well, gosh, could Lasix flare this? Well, not really. It's not a classic one that's known to. There might be 1 or 2 cases in the world's literature, but that's not the best answer. And don't get too analytical with these questions. by the way. They want you to be smart, but they don't want you to be over analytical. They will say, well, hey, I found one case report in the Indian Journal of Dermatology 25 years ago where somebody that took gold got a flare of their DH. Well, that's not the right answer. The iodides commonly cause worsening of neutrophil-rich infiltrate. So you don't want to use an iodide in a patient that's got dermatitis spiniformis. Okay, so that's the answer in this case. It's good. Hopefully you guys all got that pretty quickly. Not every single question on the exam is, a head scratcher. Sometimes they're pretty straightforward. Okay, so here we've got a shaved biopsy. It looks like a little dome-shaped papule, and notice that it's got all of these little miniaturized hair follicles in it. That's important here, because if you just saw it a low magnification, say, oh, it's not like a skin tag. It's got a little dome-shaped papule. It's got fat in the middle of it. There's really not much else going on. But skin tags don't give you little miniaturized follicles. That's helpful. That's an important part of this diagnosis here. Okay. And sometimes in this entity, you'll see a little bit of cartilage, but often you won't. Often it looks just like this. It kind of looks like a little skin tag. It's kind of usually oriented in a vertical fashion like this. It's got all these little miniaturized vellus follicles with a lot of fat in it. So what's the diagnosis here? Well, we're going to take a look, and you've got a skin tag. We just said why it's not a skin tag. You've got accessory tragus. I just told you sometimes there's a little bit of cartilage that may be seen in here, especially if there's like close to one of these branchial cleft areas there. So this is the correct answer. This is an accessory tragus. Acquired digital fibrokeratoma, never. Why? You don't get fat there. It's fibrokeratoma. It usually gives you an epidermal hyperplasia, not thin epidermis. So it's got lots of thick collagen in the infiltrate with some fibroblasts. So it's a fibrokeratoma. This looks closer to a fibroepithelial papilloma than it is that, but it's also got these small miniaturized follicles. And then last of all, supernumerary nipple. No, that will usually give you some ducts. Usually doesn't give you this much fat. And it may even actually give you some, it's going to give you some skeletal muscle in there because it's nipple. So you get some smooth muscle rather, not skeletal muscle, smooth muscle. So we don't have that. So we're missing several components of that. And normal eyelid skin. Well, it theoretically could look a little bit like that, but normal eyelid skin usually is not papillomatous like this. So that'd be the word that wouldn't be as good of an answer as this. They probably wouldn't put that on there as a choice. They might put something else on there. But anyway, this is an accessory tragus. Okay, so good. Hopefully you all got that right. They had molluscum on my exam. I thought, I've studied for all this time, and they put a molluscum contagiosum on the exam. Well, how dare they? So they may have something that's relatively simple on there for you as well. So don't expect everything to be difficult. This one is extremely challenging, but you should be able to recognize the pathology pretty quickly. It's challenging because you got no genes here. So this is really more of a basic science question coupled with a histopathology question. So we've got a punch biopsy that shows no inflammation. Something's going on down in the dermis. Well, what's going on in the dermis? Well, hopefully this is one of those where you have to be able to recognize the pathology. So what is this stuff? Well, it looks like steel wool, okay? And hopefully by now in your 30, you recognize when you get these coiled elastic fibers that if you look carefully at little tiny bits of this sort of basophilic material at the very periphery, which is this little dystrophic calcification of these elastic fibers. They're coiled, they're irregular, they're in the lower part of the dermis. This is a classic pattern of what we see with pseudoxanthoma elasticum. So they're testing you, first of all, what is this? So have you studied enough of your slides over the last 3 years that when you look at this, you can recognize this as being PXE? Okay, so hopefully you can do that. So look at those digital slides that are scanned in and make sure you can recognize this at PXE. If you can't, go back and find some other slides, go to the internet or whatever, look at it and learn it, because you've got to know this, because they're asking you a second order question. This rare inherited disorder. Okay, they could even be, if they really wanted to be a little nicer, they might say associated with an abnormality of their vision, perhaps coupled with this sort of chicken flesh-like skin and the around the neck and in the flexural areas, is associated with which gene mutation. So you got to know these gene mutations. And so you just have to know that associated with PXE is this ABCC6 gene mutation, 16p13.11. If you don't know that, you're dead in the water. So I'm not a basic scientist. I don't spend a lot of time learning genes, but you, for purposes of this examination, need to know the gene that's associated with pseudoxanthoma elastica. And so me, as a dermatopathologist, I'm teaching you what you need to know to recognize PXE in case they ask you the gene that's associated with PXE and they expect you to recognize from a picture or from a slide. So just realize that it's associated with that. Now, I don't know all these other genes, but I know a couple of them. I do know that PTCH, the patch gene mutation, is associated with basal cell. And I do know that the CYLD gene is associated with Brooks-Spiegler. That's the cylindroma gene, which is, I like it when they name the genes that you can figure out if you're dumb like me. The ATP first gene, I think that may have to do with ATP transportation, calcium channel transportation, possibly in dairies, but I'm not going to, don't quote me on that. And FLCN, I think that may be filaggrin gene that may be associated with one of the ichthyoses, but I'm not a gene expert. So you should go back and learn those genes and make sure you know which ones they're associated with, especially if I knew a couple of them, that mean they're going to expect you to know all of them. So make sure you know those for the exam. But also make sure you know how to recognize PXE. And they also might ask you about which drug might be associated with PXE-like change. And that is obviously penicillamine, which gives you the so-called bramble bush type of morphology. One other thing they could possibly ask you about PXE is which special stains are useful in diagnosing PXE. And that's the von Casa calcium stain, which highlights the dystrophic calcium of the calcified steel wool-like elastic fibers. Okay. All right, let's move on to the next one. Okay, so this is a beautiful example of this disorder. And this is another one they're going to expect you to recognize this. So we have a punch biopsy. This is probably taken from near the genital area. It may not be actually the genital itself. It's obviously not mucosa because it's got some hair follicles, so it may be near the mucous membrane. But what do we see? Sparse infiltrative lymphocytes. We've got this papillodermal edema, and then we've got sclerosis of this papillary dermis here. And we've got this thickened cornified layer because it's been rubbed. This disease is itchy. Patients rub this disease, rub the area, strikingly pruritic. So what gives you papillodermal edema, sclerosis of the papillodermis, with lichen simplex chronicus and a sparse infiltrative lymphocytes? Usually at this stage of the game, it's not lichenoid and dense. Hopefully you recognize this right away as lichen sclerosus heterotrophicus. Remember, sclerosis is decrease in the number of fibroblasts with homogenization of the collagen. That's sclerotic collagen, sclerosis of the papillary dermis, that equals lichen sclerosus. And you notice the effacement of the epidermal retius. Sometimes you can even get blisters, hemorrhagic bully, because there's a separation of the epidermis from the sclerotic papillary dermis and lichen sclerosus. So that's LSNA. So guess what they did? They expected you to get the diagnosis of LSNA fast. And then they expect you to know diseases that can be associated with LSNA. And an uncommon but important complication of this lesion is the development of dysplasia and squamous cell carcinoma. That happens to be yes, that's the right answer. Sometimes people that have longstanding LSNA can actually develop squamous cell in their LSNA. Mycosis fungoides, is that ever seen in LSNA? Never heard of it. TEN LSNA? No. Sporotrichosis LSNA? No. No risk of complication exists. Well, there is a risk of complication. You can sometimes get squamous cell. So that's the answer here. But the most important thing is that you were able to recognize that this was LSNA. So when they put something that's so classic that really just doesn't even have much of a differential diagnosis, that's when they're going to go through and give you the second order questions. They're not going to ask you to kind of try to figure it out and then ask you a second order question. It's going to be pretty straightforward. Okay. All right, let's look at the next one. We'll look at this half of it here. Okay, so we got a shave biopsy, and this time we've got a neoplasm. Neoplasm. Is it benign or malignant? Well, seems to be small, pretty symmetrical, pretty well circumscribed. Is it epithelial or non-epithelial? Well, it doesn't look like traditional squamous epithelium. If it's not, if it's an epithelium, it's going to be some sort of maybe a neural crest cell, or some people refer to nevomelanocytic lesions as being, kind of an epithelium. So it's going to be something like that possibly, but it's certainly not going to be anything related to the classic epithelium like the squamous epithelium. It's not going to be follicular. It's not going to be basaloid. It's not going to be eccrine or apocrine most likely. So it's going to be something along those other lines. If it looks like it's nested at low power, I think maybe it might be nevomelanocytic. So we think it's going to be benign. Nevomelanocytic, it's probably going to be a nevus, right? If it looks benign, we don't think it's going to be melanoma. So if we get in the nevomelanocytic category, it's either going to be melanoma or not. Well, if it's not melanoma, well, then we say, well, it's going to be, some type of melanocytic nevus maybe. So let's take a look at it. Well, what's interesting about this case? Well, it's got all of these very large cells that have abundant pale staining cytoplasm, clear cytoplasm. So clear staining cells in the dermis. What are some of the things we think about? Well, given the fact that there are nevus cells here admixed with this, we start thinking, well, maybe they're balloon cells of a balloon cell nevus. Could it be melanoma? Well, probably not, given that it's got those other features of that. But obviously, whenever we see pagetoid cells or cells that have been a cytoplasm in a melanocytic lesion, we always, kind of tap the brakes and ask ourselves any chance it could be melanoma and make sure that no mitoses or atypical cells or anything else in there that's kind of breaking the rules. But here we really don't see anything like that. So we would favor the diagnosis possibly of a balloon cell nevus in here. And what are some of the items you have to think about when you just have abundant pale cytoplasm within cells? We think of other cells that can give you these clear staining cells in neoplastic diseases. Well, guess what? That's what the board is testing you about. So let's take a look at and see what the choices are, what the question is. 35-year-old woman comes in for evaluation of a concerning nodule on her face. The best diagnosis is, okay, clear cell syringoma. Can you get clear cells in that? Yes, you can. Can those cells sometimes be nested? Yes, they sometimes can be. But what else do you see in syringoma? You always have ductal differentiation. Do we have any of that here? No. And do we have any other areas where there are some obvious nests of cells here, like over here, which are obviously nests of a nevus? We do have that. So that's going to rule out a clear cell syringoma. So that's out of the question. Metastatic renal cell carcinoma. Well, you do get clear cells in that. Well, what else do you see there? Lots of vessels, and you don't get nesting of cells like here. So those things are bloody, a lot of blood vessels with atypical cells, mitotic figures. None of those are seen here. Xanthoma, you clear cells in that? Sure. But what about nesting? No. And what about the cytoplasm of xanthoma? They usually kind of have a bubbly, foamy cytoplasm. That's sometimes kind of grayish blue because the lipid sort of looks bluish gray. Here, you really don't have that. It's just sort of granular and slightly grayish. A clear cell sarcoma of soft parts. Well, that's a type of melanoma that can occur on volar skin. We think it's a variant of melanoma possibly in the melanocytic category, but that's atypical with atypical cells and mitoses and much larger, much denser, more cellular. As a general rule, when they throw something on there that's way out of left field on the exam that you don't even have never heard of, that answer is usually not one to choose. It's usually going to be one that you know about. The board is eminently fair. They're asking you fair questions. So they don't really expect dermatology residents to know that much about clear cell soft part sarcoma. That's really more for dermatopathology fellows. for pathology people. So they're not going to really expect you to spend a lot of time and know a lot about that. So don't worry too terribly much about knowing too terribly much about that entity. Okay, so that's probably not going to be on the exam. So again, you don't have to worry so much about that. So this is an example of a balloon-celled nevus. Nice example of one. And those questions that they're asked about this would be theoretically fair, something that you could possibly get. A little bit esoteric, but not out of the realm of possibility. Okay, this one is in the realm of possibility, and it's also one that's fairly straightforward. I think they would probably expect you to get it. It's a beautiful example of this. Excellent biopsy done by a superb dermatologist. I'm not sure who did it, but whoever did it, these are the kind of specimens that we just love to get in our laboratory, and it's just a gorgeous example of a beautiful example of this disease. So what do we see here? Is it inflammatory? Is it a neoplastic process? Well, it's an inflammatory process. It's got pale cells in it. So whenever you see pale cells, it means they're usually histiocytes. We want to think that this is most likely going to be a granulomatous dermatitis. And there are several different patterns of granulomatous inflammation. I won't go through all of those with you today. Hopefully you've learned those in your residency program, but this is the classic example of so-called palisaded granulomatous dermatitis. It's got, when we say palisade, you've got these histiocytes that are palisading around the center of something. And we always ask ourselves, what is the pattern of the palisaded granulomatous dermatitis here? It goes from top to bottom, side to side. Some people refer to that as a layer cake pattern. If you want to think of it that way, that's perfectly fine. But realize that that's a classic pattern, and it's classic for this entity, which is necrobiosis lipoidica diabeticorum, and you can see that at low magnification. We'll go to higher magnification, but if you go to higher magnification, you can see that it's got degenerated collagen in the center of the palisade. Here's the palisade right here, just like that old fort back in Daniel Boone's day, surrounding the center material, the so-called, we also refer to these as the thesaurusmoses, because a thesaurus is a treasure, and this is the treasure chest, and this is what's in the center of the treasure chest, if you will. So the way to think about these, degenerated collagen, and then you get infiltrative lymphocytes and also some plasma cells. And the collagen is often sclerotic, multinucleated histiocyte, plasma cell over here. Anytime you get sclerotic collagen, degenerated collagen, necrobiosis lipoidica, you get lymphocytes and plasma cells. Okay, so plasma cells are seen in NLD. They don't have a syphilis and a spirochetal disorder. So this is necrobiosis lipoidica. So the examiners expect to get the question right pretty quickly. Then they ask the diagnosis right. Then they ask you the questions. Recent lab tests, which following abnormality? Free thyroid. No, we don't care about thyroid. This isn't pretibial myxedema here, right? This isn't mucin. This is degenerated collagen. Anticyclic citrullonated peptide antibody. Well, I don't even know what that goes with. Hopefully you do, but that doesn't mean anything here. Hemoglobin A1C, 9.2%. That's high. So what disease goes with necrobiosis lipoidica diabeticorum? Diabetes. So that's the right answer. Elevated hemoglobin A1C. Ferritin? No, that wouldn't go along with this. It's not hemochromatosis. CK, MM, 250 units per ml. I don't know what that means either. I don't really care. But I do know that it's hemoglobin A1C is the abnormality here because this is associated with NLD. So again, if these are some esoteric stuff here, you really wouldn't want to pay much attention to them. So this, they could probably have given you some even tougher choices, but here they gave you hemoglobin A1C. So that's the right answer that time. Okay. I'm going to look at this one here. And just so you'll know, for those of you going to dial in here, we got 60 questions, and I'm going to be doing these in stopping and taking breaks between these. So we're doing, probably this will be the last one I do in this session. I might do another one later, but we do probably 20 at a time. And then so if you see me the next time wearing a different shirt, it doesn't mean that I got up and changed clothes in the lecture. We're splicing all these together, so you'll have one video to look at. But anyway, we're going to do 20, 20, and 20 at a time. So this is a shave biopsy. Once again, we really would probably rather have a punch biopsy, but is this inflammatory or neoplastic? At low power, it's really kind of hard to say. Can't be 100% sure. So let's go a little higher magnification and see what we've got here. Well, we got some interesting stuff going on here. We've got these cells that are pale, admixed with some lymphocytes here. And these cells also have abundant cytoplasm that looks foamy. Foam. It's got this fine, tiny granular bubbles in the cytoplasm, this kind of bluish gray. So it's foamy cytoplasm. And then we've got this down here, which looks kind of bluish gray. And this is outside of these cells. Outside of these cells. Inside the cell, cells get filled up with this stuff, they pop, and then it's outside the cells. That may be actually how it really and truly works in nature. These cells get so overloaded with this material that they can't hold any more of it, and it actually ruptures, and then it actually gets into the dermis here. Okay, so what gives you foamy cells in the skin? Because foamy is usually due to lipid in the skin. It's usually lipid, and that lipid can be in the form of cholesterol. Often you get cholesterol clefts when it's cholesterol. It can be triglycerides, it can be sebum. Like sometimes you get foamy histiocytes in cells where there's been like rupture of sebaceous glands, sebaceous lobules. It can also be bacteria like acid-fast bacilli, like Enhance's disease, where you get globi. So there's just, when you think of foamy cytoplasm, and then also sometimes it can be mucin, can be inside the cells too, mucophages. We'll talk about that. We'll look at a mucocele sometime down the road. So this is an example of lipid. And this is extracellular lipid. Lipid is outside the cell. And it can look a little bit like mucin. That's important because the differential diagnosis of extracellular mucin in the dermis can be things like granulomedullary or massive mucinosis associated with things like pretibial myxedema or some mucinous conditions of lupus erythematosus. You get like papular mucin lesions in lupus sometimes. You can get it in papular mucinosis, people with sclerotic myxedema. So you have to be able to recognize the difference between this lipid in the cytoplasm that's because it's ruptured and that's extracellular lipid. So there's really only one process that gives you that, and that is an eruptive xanthoma. Regular xanthomas don't give you extracellular lipid almost ever because they're slowly developing. This disease goes from low lipid levels to strikingly high triglyceride levels, not usually cholesterol as much. It's usually triglyceride. And then these lipid-laden histiocytes get so filled with the lipid that they can't hold any more of it, and it ruptures, and then it gives you this extracellular lipid. So here, the abundant intracellular and extracellular substance found in this lesion is comprised of, actually, someone has highlighted the cholesterol. That's the wrong answer here. Wrong answer. The right answer is triglycerides. So if your answer sheet says cholesterol, that is a mistake. So it is not. This is this eruptive xanthoma, and the bulk of this material you see here is triglycerides. Now, there are a couple other choices here. Cholesterol, again, would be more like cholesterol clefts. Usually you don't get extracellular cholesterol to this degree, and if you do, it's needle-shaped clefts, okay? Glycogen could look a little bit like the material, a little bit inside the cells here, but that doesn't give you this much material that's extracellular like this, and it doesn't give you that grayish blue color. It's usually more white. Mitochondria, no, it's definitely, these are not mitochondria. These are not immunoglobulins either. Immunoglobulins, if you can even see them in the skin, will look kind of pinkish. So anyway, that's what we see with an eruptive xanthoma associated with extensive extracellular triglyceride. There's probably some cholesterol here too, but this is not cholesterol. Okay.